Thank you so much, Dr. Srinivas, for that very kind introduction. And right at the onset, I also like to thank the organizing team, Dr. Ram Mohan, and the entire organizing team for inviting me for this talk. Over the next couple of minutes, I will take you through this topic of new onset hypertension in a 20-year-old woman lady. And what I would actually do is present to you a couple of cases that we have seen over the last few years where lady presented to us in their 20s with hypertension and how we manage them. And towards the end, I will give a brief summary as to how and what should be our approach. So I think we all have learned in physiology what blood pressure essentially is. We know it's a product of cardiac output and peripheral resistance. And though there are several factors that can change cardiac output and peripheral resistance, it makes it look very complicated. But at the same time, it gives us a good opportunity to treat hypertension by different ways and different methods. And we have practically drugs acting on many of these pathways, which help us treat hypertension. When you look at what is hypertension definition, when you look at even the most recent guidelines, which were published last year, we know that it is just not the definition of systolic blood pressure and diastolic blood pressure of 140 and 90. It is very, very important to make sure that we are able to find that out on repeated examination. It's just not one reading of blood pressure and then we say you have hypertension. It should be at least on two separate occasions, and a systolic of 140 and a diastolic of 90. Now, when you look at causes of hypertension in a young lady in her 20s, we are very keen to learn about the secondary causes of hypertension. And there is like primary and secondary in many phases of life. We know we all go to primary school, then we go to secondary school. When we do research, we talk of primary objectives, secondary objectives. When we talk of diseases, we talk of primary when we don't know what is the cause, or the cause lies somewhere far away from the or lies within the organ. But then secondary is something important because then we specifically know what the cause is. And indirectly, it gives the physician an opportunity to treat that cause. So many times, if it is primary hypertension, we are talking to a patient that, we cannot cure you of hypertension. We can probably just control it by giving medicines. But when we have secondary hypertension, at times, we are able to cure, but at times we are definitely able to make the patient feel better with reducing the number of antihypertensive drugs. So when you have a young patient, we are primarily looking at secondary causes. Now, secondary causes, there's a big list. What I would really concentrate on is some of the endocrine causes that we have seen or we need to suspect in clinical practice. So just before I start with the endocrine causes, what I thought is something really important that we all should know. And this is not what is something that is limited only to hypertension evaluation, or it is rather more general to any endocrine disorder. And these are some of the important rules that we always learn as soon as we read about endocrinology. So I thought I'll mention these 4 rules, which definitely work very well for hypertension as well. And the first important rule is that when you're suspecting a young lady to have hypertension because of a secondary cause, we always have to first prove the biochemical diagnosis and then only move on to imaging. We never jump to imaging first. Why? Because there could be adrenal lesions or pituitary lesions, which may be incidental lesions. If we are about 100 people listening right now, if we do an MRI for each one of us, 10 of us might have an underlying pituitary incidentuloma. So that doesn't mean that pituitary incidentuloma is the reason for the hypertension. So the first important thing is that always prove your biochemical diagnosis before even looking at imaging. Never do that shortcut of going to imaging directly. The second important golden rule is that we always do suppression tests for hyperfunctional disorders, and we always do stimulation tests for hypofunctional disorders. In case of hypertension, we are mainly dealing with hyperfunctional disorders. So we always should try and suppress and see that we are not able to suppress to prove the hypersecretion. The third important thing is always look at the units, especially even in India. We have patients coming from all over, different laboratories using different kinds of assays, different units. The same cortisol will be very different in microgram per deciliter, maybe very different in other units. And it's important to look at the units equally as it is important to look at the values. And the last and the most important thing that Dr. Sheshadri used to always teach us is, many times reports may be wrong, but your clinical judgment should be correct. So you don't treat the reports. There could be so many assay interferences. There could be so many reasons why a report cannot be relied upon, but your clinical acumen should always be the first thing. So these are some of the rules that we follow. And with this, I start with the first set of disorders of pheochromocytoma or a paraganglioma. We know that, it's about 1 to 5% of people with hypertension who may have an underlying pheochromocytoma or catecholamine excess, but then those who are practicing in a tertiary care center or referral center are likely to see more patients of pheochromocytoma, which may present as hypertension. We know they're called pheochromocytoma if they're arising from the adrenal medulla, but then, if they're arising from the paraganglia, either sympathetic or parasympathetic, we call them paragangliomas. The parasympathetic ones are usually non-functional. The usual clinical presentation, the classical triad that we teach in undergraduation is the triad of headaches, sweating, and palpitations. Having said that, this is seen only in about half of our patients. This is data from our own center here at Vellore. But weight loss seems to be another important feature. And it's really important to make sure that we are dealing with and making sure that clinically we ask relevant questions to find out the differential diagnosis. And not in a young woman, but yes, in the somebody around the perimenopausal age group, yes, menopause is an important cause. Last week, I had a patient who had classical symptoms of pheo, which were ultimately diagnosed to have hot flush. So let me start with a few cases. And the lady here is case number 2. But just to go in order, I'll present all the 3 siblings. The first patient is essentially a 31-year-old gentleman, eldest sibling, who presented with history of recurrent episodes of palpitations, flushing, and headache. Anybody would think of pheochromocytoma, but then he kept visiting a lot of doctors until one serious event happened. I remember very clearly he telling me, "Doctor, I was in the vegetable market and then I had such a severe episode of giddiness. I had to sit down. There was vomiting. I was taken to the emergency from there. The blood pressure there was 160 by 120. He was admitted for almost 2 weeks and the blood pressure could not be controlled well, despite starting one after the other antihypertensives. He then came down to Vellore. And when I examined him, his blood pressure was 150 by 100. And he was already on 3 antihypertensives. All peripheral pulses were well felt. No abdominal bruise. So this is something important for medical students who are listening here, that we want to rule out renal artery stenosis. So it's good to look at renal artery bruit. No hypertensive changes in the retina. Otherwise, systemic examination was normal. So the important message here is that when you have a young patient with very high blood pressure who's on multiple antihypertensives, you have to look for a secondary cause. Yes, in this patient, we're dealing with a pheochromocytoma. The norepinephrine levels were extremely high, and other biochemical parameters were within the normal limits. So urine catecholamines is something that we use in Vellore. Plasma catecholamines are also used in other centers. All said and done, you need to trust your lab and make sure you get the right value. For urine catecholamines, this was a study that was done at our center where we consider that the value should be at least 2 times the upper limit of normal for it to be, having a really good sensitivity and specificity. All said and done, after having proven the biochemical diagnosis, we moved over to imaging, and you can see a large tumor here, 8 centimeters, highly vascular, very variegated appearance. So there are areas of necrosis in between here and there, which is classical of pheo. The important message here again is that even if you see one lesion, you do not underestimate or do not think that the other lesions may not be there. And this patient had 2 other lesions as well. And sometimes MIBG scan can help you locate these lesions, and therefore it has some utility in preoperative localization of multiple lesions. After having diagnosed clinically and biochemically, we prepare the patient for surgery. We make sure that, 8 to 10 days, we are giving the patient adequate fluid replacement, good salt, as well as good alpha blockade. And ultimately, the patient was taken for a surgery. The tumor was excised. The surgery was uneventful. This is a tumor, 8 centimeters, so really big. And the patient has gone, his hypertension improved. The classical histopathology, as is described for any neuroendocrine tumor, xenin-bolin appearance, chromogranin staining that you see here. Ultimately, the patient has done well. Metanephrines have been normal. And the treatment of secondary hypertension can be very, very gratifying. So therefore, in practice, when you have a young lady who you're managing for hypertension, if you find a secondary cause, your treatment can be very gratifying. Let's look at the sister. And in this case, she's a young girl Often we see in practice pregnancy-induced hypertension. Again, a matter of concern for this lady. At 8th month of gestation, she was having meconium stain lichen, and therefore she was taken for cesarean section, but that was a stormy surgery. She underwent a hypertensive crisis during surgery, but no one ever bothered to figure out as to what really happened. Why was the hypertensive crisis there? Ultimately, 2 years down the lane, she noticed bilateral neck swelling. She was operated for the first time, and this was in another hospital. At that time, again, it was documented that intra-op she had high blood pressure. And to make things worse, she was started on beta blockers. Now, this is an important message here, that when you have a young hypertensive patient and you're getting history of surgeries where there was hypertensive crisis, you're getting history in family when there was abdominal tumors, you should not start beta blockers. You look at the result, what happened to this patient. She has an intracranial bleed. Luckily, she survived that. Overall, the physical limitations and the weakness also improved. She came down to Vellore for the second surgery. We adequately blocked her. And this was the carotid bodies tumor, which was visible just on inspection. Ultimately, now she's doing well and she remains asymptomatic. Talking about the third sibling, and this is the youngest of them all, and he also noticed neck swellings at a fairly young age. Came to CMC at the age of 19, where he was again operated, found the swelling, CT angio confirmed it's carotid body tumor, operated, post-op uneventful. He was advised surgery for the other side. However, he did not follow up. So right side was operated and left was yet to operate, and he lost a follow-up for 5 years and then came back with lymph nodes as well. So the key message here to the students who are listening to us, when you have lymph nodes in a patient who is suspected to have a paraganglioma, and if the lymph nodes show disease status, then you think it's metastasis. So you can never diagnose malignancy of a neuroendocrine tumor just by the biopsy of the tumor. You have to demonstrate that in lymph nodes, which was demonstrated in this case. It's not very common, but then malignant paragangliomas are also known. So this was a story of three siblings. Very, very important to take a good family history. As you see, the father had some liver metastasis and a tumor. Somebody else had had cardiac death. So very good important point here is to, when you have a young lady with hypertension, sit down, find out the pedigree, find out the siblings of parents, grandparents, and find out what were their problems. In this particular patient, we did the genetic analysis. Ultimately, the patients had SDHD mutations. It helps because, we can even screen the progeny, the children of these three patients, and ultimately, help them know whether they need surveillance further on or not. Overall, genetic causes are known in about 30 to 40% of patients. This is very different from the conventional teaching that we had learned in medical school, the rule of 10 that we used to talk for pheochromocytomas, that there'll be 10% who will have a familial disease. That's not true. And with more and more genes that are now coming up, it's as high as 40%. Sometimes we are very lucky. We can pick that up clinically. And in this particular patient, when they have neurofibromatosis and Caffioli macules, it was a very easy diagnosis along with the pheochromocytoma that this patient had. And otherwise, you have to look at the fundi, you have to look at abdominal imaging for renal cell carcinoma, retinal angiomas, and cerebellar hemangioblastomas. So this is a case of VHL. There could be a possibility of MTC as well. So very important to examine the thyroid in these patients. And if there is swelling, there's no harm checking for a calcitonin. So cutting a long story short, when you have a young lady with hypertension and you're suspecting pheochromocytoma, when do you start thinking of syndromes? Essentially when either the lesion is bilateral or there is a strong family history. If that is there, you're definitely knowing that this rule of 10 doesn't hold good, and a large proportion of them actually could have an underlying mutation. When you look at the age distribution, actually, it's really surprising. And we're talking of somebody at the age of 20. So it's majority here, 60 to 70% in the second decade, who actually have an underlying mutation or a genetic cause. And it's only in the latter half of the decades that the sporadic cases keep increasing. Presenting another case, and this is a story of a 28-year-old housewife. She was apparently well 15 years ago, and at the age of 13, she had noticed some headache that she used to get after passing urine. It's not a very common symptom that you would hear. This is called as micturition syncope. I, in my OPD, actually asked her to go and pass urine, and I checked her blood pressure after she passed urine and came back. It was a whopping increase of 40 millimeters of mercury systolic and 30 diastolic. So this is something very classical of pheochromocytoma, or sorry, paraganglioma in the vesicle or the paravesical region. And an MIBG scan on a delayed scan did show uptake there. Ultimately, we've had a couple of patients. Not that this is common, but the important message that I'm leaving here is that, it's not always adrenal. It is very important to screen the entire area of the parasympathetic and the sympathetic chain to try and locate these tumors. Ultimately, when you have a pheochromocytoma suspicion, you are going to check for urine metanephrines if high, first biochemistry, then imaging, and MIBG if required. Good alpha blockade. Do not start with beta blockers. Good hydration, a lot of salt loading, and ultimately this patient can go for surgery. So that's about pheochromocytoma, and I move on to my next series of patients. And as you see, these are three different girls, each of them with a different etiology of Cushing syndrome, and who presented to us. I'll show you a couple of pictures of other patients as well. But the first and the most important thing that you have to do in your OPD, when you have a young lady with hypertension, you have to wonder whether this is Cushing's or not. And believe me, this paper, which was published by Ross and Lynch way back in 1982 in the Lancet, still holds very good and useful. And this describes first time the discriminant indices of Cushing syndrome. And even in the most recent guidelines, this is what we follow. Essentially, you're looking at certain features which help you differentiate very well whether this is Cushing syndrome or this is just obesity. So if the patient has proximal myopathy, if the patient has facial plethora, patient has tri, or patient has hypertension. So these, and easy bruisability. So if these features are present along with hypertension, that's when you have to think of Cushing syndrome. After you've made a clinical diagnosis, it's important to understand the mechanisms. I'm not going to go into the details, keeping the talk more clinical than theoretical. So we're looking for clinical features. When you talk of moon phases, what it means is when you stand in front of the patient and you look at the patient, you should not be seeing any ears. There's hyperpigmentation that you see here. There's some amount of hirsutism that you see there. There's the classic lemon on stick appearance, which is described. So if you look at just the hands of the patient, you would not think the patient is so obese, but there is a large amount of centripetal obesity there. Easy bruisability, classic striae of Cushing's, which are more than 1 centimeter wide and non-tapering at ends. But the most important investigation and the most important thing that we have to do in clinical practice before we label this patient to have endogenous Cushing's is to rule out exogenous Cushing's. And this is really important in our clinical practice. I had one patient, who would just deny that she's taking any steroids whatsoever, and the cortisol was low, and she had classical features of Cushing syndrome. Ultimately, we found that she was taking these powders for joint pain. And when we analyzed that, this was dexamethasone. We recently had 2 boys, and these are brothers. And when I examined them in the OPD, I thought that this is some exciting genetic cause of Cushing syndrome, but no, the cortisol levels are rock bottom, very low. And so somebody was actually trying to poison them, give them steroids in their food. And that's the sad story there. So it is really, really important when you suspect Cushing syndrome, the first test that you do is an 8 AM cortisol. And if it is low, you're suspecting exogenous intake of steroids. And many times patients don't even realize that they're taking steroids. So it's like, really, you need to find out where is the source of steroids. Well, if the 8 AM cortisol is not suppressed, you're looking at other screening tests, loss of circadian rhythm, 24-hour cortisol, overnight 1 milligram DEXA suppression test. These are 3 tests. At least 2 should be positive. We know that this is a picture from Guyton that midnight cortisol levels are usually low. But when you're talking of patients with Cushing's, if your midnight cortisol level in the sleeping state is more than 1.8 microgram per deciliter, that is diagnostic of Cushing's. The other thing is 1 milligram dexamethasone suppression. Commonly, the 1 mg tablet is not available. So we take 0.5 mg, 2 tablets at night, 11 o'clock. Next day morning, we're checking an 8 AM cortisol. And if that is more than 1.8 microgram per deciliter, that is also suggestive of Cushing syndrome. The third screening test that we do is the urine-free cortisol. And that if it is more than, you know, 4 times the upper limit of normal, anything more than 400 micrograms per day is suggestive of Cushing's. We also do the midnight salivary cortisol if that is available in your lab. That is useful. This is something that we had validated a couple of years ago, the spot urine cortisol creatinine ratio. Just like in diabetes, instead of doing the 24-hour urine protein, we can do this with a spot ratio and found to be useful as a screening test. So at least 2 out of 3 screening tests should be positive, and then you actually look at the ACTH and the high dose dexamethasone suppression test. That is not recommended more and more in recent days. But then if the ACTH levels are low, you know that you're dealing with an adrenal cause. You go for a CT abdomen or an MRI abdomen to look at the adrenal gland. But if the ACTH levels are high, if they are less than 100, then you're thinking of pituitary cause. If they're high, very high levels, then you're looking at ectopic causes and imaging accordingly. So the key message that I want to leave with Cushing syndrome is that you have to do an 8 a.m. cortisol to rule out exogenous Cushing's as the first test for Cushing syndrome. It can make a huge difference. We know that 90% of our patients have microadenoma. This lady who was operated, you see the change in look, not only the look, when you look at the blood pressure, it makes a huge difference. And coming to my last case, and this is a case of primary hyperaldosteronism. This lady came to the casualty with 2 years history of hypertension in her 20s. You see that she is already on 4 different antihypertensive agents, and she has come to the casualty with acute onset weakness of all the 4 limbs. On examination, she has very high blood pressure, grade 3 power, proximal myopathy. And what is also very important clinically when you have a young patient with hypertension is to look at end organ damage that has caused the hypertension. You see, when somebody with grade 3 hypertensive retinopathy, you surely know that the hypertension has been there for a long time, and that needs to be taken seriously. When you look at the biochemistry here, you see hypokalemic alkalosis, which is suggestive of hyperaldosteronism. You further prove that by doing an aldosterone and renin test. And with this clinical scenario, we have to proceed for the aldosterone renin test. But again, this test needs to be done after correcting hypokalemia rather than to get any false results. If the patient is on spironolactone, that should ideally be stopped. In this particular patient, the aldosterone levels were 370 microgram per ml. Again, that very important message that I mentioned before, units are very important. When you actually look at the cutoff for aldosterone renin ratio, that is in nanogram per deciliter. So in our lab, since it was reported in picogram per ml, I would divide it by 10 to get nanogram per ml and then calculate the ratio. And then since it's high, then I would suggest that this is definitely Conn syndrome. The lesion is there. Usually Conn syndrome lesions are small. They are hypodense, usually less than 1 centimeters. And that's how this particular lesion is. Initially, this patient was planned on spironolactone and then planned for surgery. Ultimately, the patient did well. If you're not able to get a very discrete lesion as we got in this patient, adrenal venous sampling is an option. But if there is bilateral hyperplasia, then medical management is definitely the way forward. It's important to remember that in aldosterone excess, it's just not the hypertension we are worried about. It's also the ill effects of aldosterone that we see in the myocardium and all the other organs that also need to be addressed. And therefore, that's important. Earlier on, we used to talk about confirmatory testing and saline loading test. With the advances in imaging today, I think we are doing less and less of that. And overall, this patient was managed with the right adrenalectomy, spironolactone was stopped, and ultimately she was only on 1 antihypertensive drug. The important point here is that when you counsel patients with secondary hypertension who's been having hypertension for a long time, you have to tell them that, maybe by surgery, we are not going to be able to stop all the drugs. Maybe it will reduce, but we are definitely going to prevent worsening of hypertension because of the arterial changes that happen because of long-standing hypertension. It's sometimes difficult to cure it. So overall, to summarize, when we have a patient with secondary hypertension, when we suspect endocrine hypertension, when we have a young patient and has specific symptoms of the diseases that I mentioned, when there is family history, when the patient is taking a lot of drugs or has presented with very severe hypertension. On examination, we are looking at for specific lesions, making sure to examine the thyroid, looking for Cushing's and acromegaly. But having that checklist is very important in your mind because what the mind doesn't know, the eyes don't see. It may be a subtle acromegaly or a Cushing's, which we may miss if we don't think about it. Investigations, both first line and second line, there are broadly three types of investigations that we want to do. We want to establish the end organ damage. So that's why we are checking at kidney, renal functions, urine protein. We want to establish the cause of hypertension, and first by biochemistry, and the third set is definitely trying to look at the different scans. So overall, management of secondary hypertension, there are different drugs that work, but ultimately the one-line answer for management is treat the cause when you can find. So to summarize, overall, there are several endocrine causes of hypertension that we saw. Please remember the 4 golden rules: biochemistry before imaging, suppression test for hypofunctional disorders, always look at the units, and clinical acumen, more important than reports. Mention about these salient flag marks when you suspect hypertension in a young patient, bad control of blood pressure, specific symptoms, and family history. This is the investigation profile, and ultimately you need to treat the cause. Thank you very much.